It's my pleasure today to introduce Dr. Mo Modarres from our own department and also from the Shriver Center. Dr. Modarres received his bachelor's and master's in biomedical engineering from Case Western Reserve University in Cleveland, Ohio, and then also his PhD in biomedical engineering from Case Western Reserve. He's currently in our department of psychiatry, but is also has an appointment as a health research scientist at the Bedford VA in Bedford, Massachusetts. He has served as a mentor for both K23 and KL12 awards. He has a very long track record of funding. He's currently funded by the VA to do a study entitled Neurophysiology Markers of PTSD's Presence, Severity, and Therapy Outcome. And the other thing I think is very noteworthy, he is the inventor. He's an inventor, and he holds 8 patents and also is a co-inventor on 6 patents. The title of Dr. Modarres' talk today is Biomarkers of Neuropsychiatric Disorders, EEG and Functional Near-Infrared Spectroscopy. Let's give a warm welcome to Dr. Modarres.
Thank you very much for this good introduction. I impressed myself hearing that. First of all, I have no actual or potential conflict of interest in relationship to this program. And I'm going to be covering both EEG and fNIRS, functional near-infrared spectroscopy. It's going to be a lot of material, so if I sometimes rush through that, I apologize in advance because I want to kind of cover both of them. It's important modalities for analyzing brain activity, in particular to psychiatry and neuropsychiatric disorders. So I'll start with the electroencephalography EEG, where quickly, review that the EEG really represents the postsynaptic potentials of pyramidal neurons of the cortex. It's right under the surface of the scalp in the cortex. They are in the column fashion, and the postsynaptic potential is what we measure as an EEG. There are a multitude of devices that currently, is used for clinical and for research applications. There are systems shown in the left where basically, big clinical, hardware and usually, puts on a stand to move it around. And it's, multi-channels ones, as you see, 30, it can be as, low as like 20, but up to 256. And then there's this portable ones that is more and more is being used for clinical and for research, because they are, basically, as you see, very portable, and they can be, patient can wear them and they're able to sleep with them, to walk with them, and so on, such as this one. And they are, even convenient for the babies as far as these active electrodes that makes the attachment easier. But anyway, so spectrum goes from the, big clunky systems all the way to really small ones that the person can wear. Clinical EEG analysis is currently mostly based on visual inspection. You see an example on this left side where I'm showing polysomnography or sleep study. And basically the EEG, the screen is zoomed out or zoomed in such a level that a person can visually look at frequency contents and a shape of the curves. For example, in the awake, we see there is a lot of, this is awake, before falling asleep. So it's really awake, drowsy. So it's a lot of, alpha activity that even visually one can see them over here. And then as they go through sleep, the alpha, kind of goes away, and the lower frequencies of delta, and up to deep sleep where this, theta, this delta curves, low frequency, high amplitude happens. And then we go back to REM, where there is, again, looks like awake, but with a distinct, distinct type of, sawtooth waves and so on. So, normally the people that sleep expert looks at 30 seconds epochs at a time, and then assigns a state: awake, stage 1, stage 2, deep stage 3, and then REM. And then they produce what's called a sleep architecture or a hypnogram. And you see overnight, this is for a normal person, that they go to deep sleep in the first part of the night, and then they go to REM in the latter part of the night toward the morning. That's why a lot of times we remember our dreams coming from this part, late in the at night or early in the morning. And that's from this, the shape of this hypnogram, from the depth and the variability of that. They are doing research that shows how normal subject sleep is different than PTSD, where in this case they had a lot of fragmentation and didn't go to REM sleep, this particular patient. But you see the difference, and that is being used as a means of separating them and analyzing it. Another big application of clinical EEG is really in epilepsy and seizure monitoring, where again, if you open up the signal, you can see that at the time of seizure, that's here actually, around that time, you see the signal EEG becomes, low frequency and high amplitude rhythmic waves. And anyway, so these are all based on visual inspections and so on. Quantitative EEG, and that's what is the focus of our talk today, is came out about in the late 1990s. And what it does, it utilizes complex mathematical algorithms to extract EEG signal features that are related to the underlying, neuropsychiatric disorder or condition. And usually the EEG acquisition for this type of test analysis is done for some specific test paradigms. For example, the subject is in a resting state, eyes open, eyes closed, laying down, awake or falling asleep. And that they're also, during the test, where they're engaged in attention, memory, cognitive tasks, and again, during sleep. And there are various types of QEEG analysis that I'll talk about: spectral power, coherence, and complexity, which I won't cover it here because it has whole new other mathematical things going with it. But mostly it's spectral power and coherence. And I'll go through and explain what they are. So for spectral analysis, it is based on characterization of average spectral powers of individual frequency bands and from individual channels. So to make it easy, I have one example of EEG from one channel during the awake to sleep transition. And essentially what QEEG does, it takes these signals and it passes through a bandpass filter or a prism, just like we do it with white light. And we find out all the different components of that EEG. The components are usually put together in bands such as delta, which is 0.5 to 3.5 hertz. Hertz is the cycles per second. Theta, alpha is the prominent one, especially when we close our eyes. And that is 8 to 12 hertz. So which means that, you can count 10 of these oscillations in a 1 second part of a signal. So basically what we do, we decompose the signal. We find out all the components that are mixed together to make this EEG. And then we look at the amplitudes of all of these, each of these components. For example, with the alpha, you see there's an amplitude here. And it's actually amplitude is squared and is plotted against the frequency. So here is alpha. When you square it, this is the value, and this is for alpha. Same thing, we do it for beta, same thing, and then for theta and other ones. So this is what then, becomes a spectral power curve, or call it power spectral density or whatever. And all it is that for each frequency, it shows what is the amplitude or amplitude squared of the underlying signal. So if the signal is, for example, all alpha, it would be just here, and then these other places will all go down to zero or to close to zero. So that's what it shows. For that particular piece of signal that we're analyzing, this shows what are the amplitude squares of them. And then we can look at them in both in absolute and relative terms. Absolute is what I'm showing here. And relative term would be you take this absolute curve and then you divide them by the area under it. So basically then alpha is not just the activity, but it's the percent of activity in this alpha range. And beta, same thing, percent of activity in this beta range. The one step further is that, we go into time frequency analysis or a spectrogram where, we have this type of spectral plots that we saw before over time. So this would be time 1, time 2, time could be every second, for example, and so on. And then we will stack them together and we get a curve such as this one, where we have frequency here in this x-axis, sort of time in the y-axis, and the curves or the plots are colored such that, the more yellow, brown, yellow, and red, it corresponds to a higher power, like a heat map. And the blues are the lower power. So look at here, go back to our raw EEG. At time 9 is where they actually fall asleep. And that is based on this clinical method that I talked about it before. A sleep expert determined that. Now we look at this, QEEG type of plot, and we see that the person had basically alpha power all the way to here, to 9. And then it starts to, lose some of them. And then once he goes to deep sleep, once he go to sleep, then basically, the alpha power goes away. And what happens is that then you start getting power in the lower frequencies, in the delta and the theta range. And in fact, a more common way of doing this is this spectrogram, where we kind of look from the top at the figure. And this is what we get. It's exactly the same thing, but looking down at it. And we see that, up to the point of falling asleep, determined by the sleep expert, we had mostly alpha wave. And as soon as they fall asleep, alpha goes away and delta and theta comes up. So that was the spectral analysis. The other method that we use is coherence, which measures the synchronicity and correlation between EEG signal pairs. So now we look at, for example, 2 signals, F3 and F4, corresponding to the frontal of the forehead at the right and left. Odd numbers are left usually, and even numbers are right. So F3 frontal left and frontal right. So what coherence does, it has basically 2 components. It's a magnitude, which is related to cross-correlation between these 2 pairs. It really is looking at how synchronous, they go up and down together. And then the phase, it just shows that, whether and to what degree one is leading the other one. So it's a measure of directionality, if you will. If somebody is leading the other one, signal, we assume that, that is the information is going from the leading one to the lagging one. And to make it a little bit easier, then I'm showing this coherogram, which was similar to that spectrogram that we saw before, except that now the colors corresponds to the magnitude of the coherence. And the coherence is a number that goes between 0 to 1. 1 means it's perfect synchrony. 0 means no synchrony, no coherence. They don't follow each other in any way. And so so the higher the coherence, the more the hotter the color, if you would. And now we're looking at another case, falling asleep at this point. But now I'm looking at these 2 frontal ones, and we see that again the coherence is high at the awake period, and once they fall asleep, the coherence goes away. Now let's look at just that small 2-second portion of the signal that has been basically filtered, and for the alpha wave part of it. You see the alpha wave between the 2 when they were awake and highly synchronous. You see how nicely they go together. Basically, they follow each other perfectly. In the sleep, when the coherence is low, you see that now there is synchronicity is basically diminished, and that they sometimes they're synchronous, sometimes one leads the other one, and then one lags, and also the amplitude of the signal changes. It's not just the phase, but the amplitude changes as well. Whereas here the amplitude was mostly the same. So that's how the coherence works. Looks as how synchronous these data are, and we do that when we do this multiple type of testing with all of this, all of EEG channels. We look at their coherence between all the possible pairs. So we have lots of pairs to work with. Now I'm going to basically do a little bit of literature review and show that what are the clinical application on QEEG in neuropsychiatric disorders. Currently, the role of QEEG is complementary to standard clinical methods, to generate objective information in order to obtain a precise diagnosis, correct disease severity assessment, and specific treatment response evaluation. A few of the clinical work that has been done with epilepsy, stroke, TBI, learning and attention, and other applications. And basically, quickly, what I want to show is that mostly they show that epilepsy compared to healthy is the theta wave increasing it, and also theta wave increase in the intra and interhemispheric coherence. Okay, in stroke, the ratio of theta to beta goes up in the damaged hemisphere, and that in frontal side, the delta to alpha ratio also go up. In TBI, alpha frequency power goes down, and the coherence in the phase between frontal and frontotemporal, it also goes up like this one. And the learning and attention, there is an increased low frequency associated with the low IQ, and coherence is positively correlated with IQ. So all of these things, if I can summarize it, it shows that, mostly they show that the low frequency activity in the delta and theta goes up and the higher frequency activity goes down. That's the bottom line of that. Now, the magnitude different and so on, but the gist of the results is that there is an increased low frequency and decreased high frequency for clinical applications. For research application of QEEG in neuropsychiatry, I use this reference here, this very nice review that shows, the type of work is done with ADHD children, adults, schizophrenia, autism, depression, OCD, PTSD, addiction, and panic disorder, and so on, anxiety. It shows a number of studies. It shows that the number of subjects used in each one. So in the mid 50s to 100, that's basically what it is in the upper, in the 70s or so. Percent of control, about half of them are usually, normals and controls. Their ages, depending on the application, but these studies are more younger type, if you would, up to 40 years for PTSD. And that they have female in all of them, that can be as high as 76%, but mostly in the middle, 30 to 50%, and that they have both eyes open and eyes closed. A lot of them are eyes closed, but there are some that have eyes open in them as well. And what are the findings in this type of research applications? I'll start with the left side at the major depression, where they show that there is a slow wave asymmetry in the frontotemporal areas. There is a alpha frontal asymmetry. There is a reduction of interhemispheric coherence in the delta and theta, in the low frequency bands. There is an increased right hemispheric delta and theta, and an increase in the ratio. Basically, it shows that the coherence is lower, but the amplitude of delta and theta activity is higher. Even here, when you look at the ratio, basically, increase is due to increase in theta and decrease in beta. On the right side is a nice table, again, from this review, but it shows, how does the activity in delta, theta, alpha, and beta is different across the different diagnoses. And for example, in depression, we see that delta and theta power goes up, and beta goes up as well. In ADHD children, we also see, increase in delta and theta, but a decrease in beta, and so on. And I will show, for example, in autism, is actually a decrease in delta and a decrease in beta. So this is eyes closed, this is eyes open. But basically, one thing that comes out of this is that this is all nice, but look at, different diagnoses, different conditions have similar changes in their delta, or in their theta, for example, here, in the alpha, in the beta. So, if we just go and say that, in ADHD, for example, that there is a, increase in delta and theta, well, that could be in other situations as well. It could be depression as well. And the importance of this is that a lot of times, this diagnostic, basically they're co-diagnostic with them as well, PTSD and depression, and so on. And even autism and ADHD symptoms, it used to be thought that, people either have ADHD or ASD, autism, but they could have also, for example, with ASD patients, they could have a bit of, for ASD, a bit of ADHD type of maybe hyperactivity or inattention, and vice versa with ADHD have some autism symptoms. But they would say the primary thing is either autism or. But recently they have come to this, to the new diagnostic of a combined ADHD and ASD. So the combined one is different than either of them alone. And that poses a problem in terms of accurate diagnostics, and also for people who show symptoms of both of them, and also the correct type of medication and therapy that would be assigned to them. So it is important to go one step further than just finding the difference in QEEG, which has been replicated and all, and try to find out how can we link that more specifically to the underlying condition to be more sensitive and specific. That's the word, sensitive, specific. Basically, then, in order to come up with what I really describe as a biomarker for these disorders, the observed QEEGs, since they are shared, what we need to do is to develop these sensitive markers by using this type of general approach. When we do a statistical analysis, we don't just compare, for example, ADHD with controls. We need to also add ASD and ASD plus ADHD in order to be able to come up with a signature or the feature of the EEG that separates the groups that can be used as a biomarker. And that, then, once we find that, then we can combine them into, we can either put it in an if-then table, a tree table of classification, or even better, put them through some type of a machine learning method that basically, combines them in a way that visually it's hard to do, and come up with the best way of combining these features of EEG that separates the groups and is highly sensitive to the real correct underlying situation. So I'm going to now show the results of some of the work that we are doing here at Shriver. And these results is for, against separating ADHD, ASD, and combined ADHD, ASD from controls, try to develop biomarkers for that. So that's our eventual goal. And we started by using a biobank of high-intensity EEG recording, which was created by the Child Mind Institute. It's a public database. And that in that database, it was many conditions, but we focused on at the beginning on the resting state paradigms, 5 minutes, where children 5 to 16 years of age, they looked at the fixation cross on the center of computer screen with their eyes open and closed. 20 seconds eyes open, and 40 seconds eyes closed, and they repeated 5 times. The group, again, had typically developing 86 of them. They had 8 ASD alone, 38, and 120 ADHD alone, and 114 ADHD plus ASD. So what are the results? First, the first thing we did, it was a high-density EEG recording. We focused on these 31 channels shown on the top left to sort of reduce the complexity of analysis and also the redundancy, because channels could also provide similar things when they're close together. And that we did two major parts. We did a power spectral analysis, just like I showed before on these 31 channels. And we looked at a little bit of a more narrower band frequencies. For example, I split alpha into an alpha 1 and alpha 2. Alpha 1 is 8 to 10. Essentially, alpha 2 is 10 to 12. Same thing with beta. I looked at 12 to essentially 15 or 16, and beta 2, beta 3, beta 4, and then the gamma. Usually people say anything above 30, call them gamma. We put them into 4 different scales, ranges from 30 to 40, 40 to 50, and 65 to 75, and 70 to 100. We see in the results that is actually this makes it's important because had we not separate them into these fine grains, then we might have missed cases where, for example, only beta 3 was significant between the groups. And if you had all the betas together, that might not have shown. So, and by the way, some literature is also supports doing this. So it's been done. Anyway, so 31 EEGs at 12 frequency bands. And for coherence, we look at these 31 frequencies and we look at the coherence between them. But then what we did, again, to reduce complexity and to make these results a little bit easier to handle, we grouped these electrodes into what we call areas. So for example, look at the lower right, we have a left frontal, which is, these channels here, and what I'm showing with the mouse. We have left frontal, right and left temporal, right and left central, right and left parietal occipital, which again, I put them together. This is the first round, so eventually we can even go and make it more granular. But for now, I just want to look at the regions that sort of goes with the lobes also, frontal lobe, temporal lobe, parietal occipital lobe, and then the central area. So we did the coherence on these as well. I am now showing the results of these comparisons. I'm showing the power, in this case, relative power, and that I have color coded them such that, for example, blue is for typically developing versus ASD, green is ADHD versus typically developing, and this pinkish one is for ADHD plus ASD versus control. And then on this other column here, this sort of, I don't know, gold, whatever it is ASD versus ADHD. Red is ASD versus both. And the gray one, gray one is ADHD versus both, and the red one is ASD versus both. And I put the results in a table here, but what, we don't need to look at that because I have it also in this head map. What I put here, which is wanted to point to, is that these are the places where our ANOVA essentially, produce a significant results, ANOVA among these, 4 groups. And that I'm only showing those cases, the locations and the frequencies where this thing was significant. Here, in this, when I have this color mapping here, this table, I'm basically showing the power for each of these cases where we detected significance. And the reason I'm doing that is because I wanted to show that, for example, ASD, for all of these cases, the relative power of ASD went up. So at all of these locations, AF4 at gamma 1, gamma 2, FP1 at beta 4 to gamma 4, all of them, we see an increase in ASD. And so I put these results, all the cases where there were significant difference among the groups, I put them into this map. Colors match the same thing here. So for example, this one is FP1 here, where we have a significance in terms of ASD versus controls. and also in terms of ASD versus ADHD. So that's why I said that in this area, these two groups are different, with the frequencies shown here, and so on. What came out of these results, which is very exciting to me, is that, only here at T8, at gamma 1 and gamma 2, we see that ASD had the larger power compared to TD, ADHD, and ADHD plus ASD alone. So, in other words, T8 at gamma 1, gamma 2 could be a potential biomarker for ASD that is also different than ADHD and combine them. So, that can be used, for example, if there is a question about person is kind of ASD alone or has, ASD and ADHD, has ADHD, both of them, we can, get their T8 at gammas during an eyes, this is eyes closed condition, and we might be able to, come up with some conclusion about where they are in terms of severity or the uniqueness of their ASD.
Yeah, I'll get out of here. Thanks.
Same thing I'm doing now with the coherence, and I'm basically showing the difference in coherence among the 4 groups. Let's just look at the bottom graphs here, bottom plots. Basically, what we are saying is that during the eyes closed condition, this pink one, which is ADHD versus ADHD plus ASD versus control, we see that, that goes down, that the coherence goes down compared to controls. Coherence goes down in ADHD compared to controls in this area between left frontal and left central, and at these frequencies that's shown here. In the left temporal also, there's a decrease in ADHD plus ASD versus control coherence. But the coherence of ASD versus ADHD goes up. So there's more coherence in autistic compared to both groups in the left temporal area. Even more exciting is when you look at now eyes open, between left temporal and left parietal occipital, we see that all 3 of them, which is ASD versus the other one. So this gold is ASD versus ADHD, red is ASD versus both, and blue is ASD versus controls, normals. We see that all 3 of them, the coherence of ASD group goes up. So again, this I call potential biomarker, left temporal to left parietal at alpha 2 and beta 1 could be used as a biomarker that is more specific to ASD compared to other groups. I'm going to go quickly talk about other biomarkers that I did. I did this with ADHD during the time where the person was performing a continuous test of an oddball paradigm responding to target and non-target tones. And the results show that, in the top is the EEG one on the left, and the reaction times is shown here. This negative ones is the times where this is an error of commission, but they were supposed not to respond and they responded. And the top and the other ones are reaction times, and if they missed it altogether, then it shows as this thing at value 2. Sorry. So basically, we are saying that in normal adolescents versus ADHD, there's a difference in terms of their brain activity during this 15-minute test of oddball paradigm, and in terms of reaction times. As you see, the ADHD missed quite a bit, and also had commission errors as well. We put them together. So now, what I did is I went one step further for just QEEG. I get the QEEG, I get the parameters from that, and then I combine them with this reaction time, with their behavioral response, with the push button response. And we looked at 45 children between 8 to 17 in 3 groups, each of them 15 subjects, normal control with no history of ADHD, diagnostic ADHD, but before study medication, And then group 3, the positive history of ADHD medication on a stable dose for at least 30 days. And when we look at this, ADHD specific biomarker, we see that ADHD new diagnostic was quite different and larger than normal control. And after they take the medication or the group with the medication, the differences became less and wasn't significant, at least statistically. There was wide range of response, but on the average, they did not respond. So in the interest of time, I'm not going to talk about the PTSD. I'm just going to jump into the functional infrared spectroscopy. So far, we looked at electrical activity of the brain. With fNIRS, it is similar to MRI or fMRI that looks at the Bolt signal, the blood oxygenation. And that it injects light in the brain, on the surface of the brain, inject lights, and then it detects it a few centimeters away. And based on the attenuation of the light, it comes up with a measure of blood oxygenation or Bolt, which is similar to an fMRI. It is very similar to a portable EEG, if you would, in that, you can basically put the headband on babies, literally 3 months babies that we are doing at Shriver. Dr. Suri Kim is doing that all the way to elderly, obviously. And that, it is fairly practical to use, even better than EEG. You can walk with it, you can have movement. It doesn't get as much affected by movement artifact as an EEG does. But it measures a different signal. It measures, blood oxygenation. And it has a poorer spatial resolution compared to EEG. And that also, it lacks anatomical information. It's better than EEG, but not as good as fMRI. So what is it and how does it work? Basically, when there's a change of neural activity, it evokes hemodynamic response. So when you start to think about something, whatever, you start to get a hemodynamic response, which goes, and that will then in turn changes oxy and deoxyhemoglobin concentration. So here you neural activity, and that decreases oxygenation and deoxygenation of hemoglobin. At the same time, you get a cerebral, you get a response for the cerebral blood flow control, and that increases. So the blood, volume and flow increases, and that would increase your oxygenation and decrease your deoxygenation. The combination of the two, or the net result, is that neural activity essentially comes up with more oxygenation hemoglobin and less deoxygenated hemoglobin. Okay, so that's what we're trying to measure. And how do we measure that? It happens that infrared light, I'm showing it on the left top, the rate of absorption falls or is above water right between 650-ish, or between 700 to, I don't know, to 800 or 900 nanometers of light, which means that at this point, water doesn't, the light doesn't get absorbed by the water. It gets absorbed more by hemoglobin. So any attenuation we get is not due to the water absorption, it's due to hemoglobin, which then, through modified Lambert's law, which I'm sure you all remember, that it basically, when you have emitter light going in and the detector comes out, based on the light attenuation, we can go back and get an information about the concentration of the material that absorbed the light. So in this case, some of it gets absorbed by hemoglobin, but some of them escape and get detected. And so this detection, when we compare this one to the emitter one, amount of reduction is then related to the change in hemoglobin. And that's the essence of it. And that's why we can measure these Bolt signals. And it uses a continuous wave. That's not very important. One thing to remember is that, when we put the source light here, and we detect it here, the farther away the detector is, the more of the depth we can measure in terms of the hemoglobin. The problem is that the signal to noise ratio also deteriorates. So the signal is not as good as if you put the detector close to it. But the problem is that if you look close to it, you only measure really activity in the scalp and skull, but not in the gray matter. So there's trade-off, and the optimum separation is 30 to 35 millimeters in adults, and in infants a little bit less, and it penetrates about half of the separation distance. So if you go 3 centimeters separated, then we're really looking at 1.5 centimeters deep in the brain. And here I'm showing that that the fNIRS and fMRI, basically when they do simultaneously, they show very similar changes. So it is reliable in terms of picking up the changes in the oxy and deoxyhemoglobin. And that for the analysis of fNIRS, if we do an experiment where for example you provoke the system by some type of stimulus, and then you wait long enough, here you see you get an increase in hemoglobin and decreases. It takes about 35 seconds before the oxyhemoglobin goes back to baseline, and deoxy that decreases comes back up to baseline. So if your experiment is such that you can wait 40 seconds at a time, then the best analysis is that get these signals and just average them, because there is no overlap. So each one of them, you can just do an average of the plots on top of each other and get this sort of response that I'm showing here. Hold on a second. The problem is that if the response is not attenuates within the time that you're repeating the experiment, then you're going to do overlapping them, and in that case you cannot just average them, because now your signal, a point of the signal, belongs to the stimulus that just came. The other part of the signal is from stimulus that came before that, and so on. So it's kind of a convolution going on, and you need methods for deconvolve that. And that one particular method that is being used is what's called general linear model, where basically what they say that we assume we know the shape of the hemodynamic response to be something like this, such a Gaussian curve. If we know that's the shape, and if we know what we measured, then you can basically deconvolve from this measured signal the shape of what we know it's going to be there, and find out, go back and find out what was the signal that triggered this response. Anyway, I am now going to quickly talk about a few clinical applications of fNIRS in children with psychiatric disorders. We have seen that fNIRS in ADHD, and they have done it through this cognitive task, Stroop task, reverse Stroop, go, no go, and they usually do it over prefrontal cortex. Why are they doing that? Because there's a relationship, known relationship between the core symptoms of ADHD, such as inattention, hyperactivity, and impulsivity, with executive function impairment, which is mainly reflected in the prefrontal cortex. So that's why they do fNIRS, they put it there. The other reason is that it's easier to put over no hair, but that's practical reason. You just put it in the prefrontal areas. And what's the finding is that ADHD is decreased in the inferior lateral PFC during the Stroop colored word test. So this hemoglobin, or the bold response, is lower in ADHD. There is less activity going on during this Stroop colored word task. That in attention severity in ADHD is negatively correlated with the right lateral PFC. So this is with inattention severity. And also there's a decrease in ADHD bold activity in right prefrontal cortex. And the left, they have shown that actually they show the compensatory function. So the right was decreased in ADHD, but the left was increased to compensate for that. So that's the thing, sort of information that one can get from ADHD. In terms of autism and ASD, the studies are done there are kind of 3 types of studies that's been performed. Those focused on social difficulties, where they have looked at the high-risk infants, 4 to 6 months of age, and they showed a decrease in activation in the temporal cortex now in response to visual and auditory social stimuli compared to low-risk ones. ASD group also shows a decreased response in the IFG, inferior frontal gyrus, compared to controls during a self-face recognition and imitating facial expression. So these all then becomes potential biomarkers using the fNIRS now. And then there was abnormal activity in the frontal cortex in the IFG and PFG where performing joint tasks. The second type of work has been done is on non-social difficulties. And for example, for a letter fluency task, ASD showed decreased prefrontal activation. And for, during a task that they were listening and ignoring and go, no go, and so on to evaluate, inhibitory control, there is also a reduced activation in the right prefrontal cortex. And then finally, they look at the brain functional connectivity, similar to our coherence that we talked about before. And they find that there is decreased functional connectivity between the frontal and temporal cortex in high-risk infants with siblings with ASD. And then there was a decrease in connectivity between the interregions in the right prefrontal cortex in patients with ASD compared to the controls. And there was a decrease in functional connectivity between bilateral temporal lobes in children with ASD. I'm going to finish the talk by showing a study that's been done at our center by Dr. Soye Kim, where the fNIRS is being used to measure the infant's neural coordination with the mother at 4 months of age, and then again at 6 months, I believe. So we are now doing simultaneously measure in real time brain activity from both mothers and the babies. And we're looking at the degree that these brains coordinate. So immediately when you hear coordinate, we think of coherences. So we're looking at now coherence between them. And that, the idea is to find a biomarker that will show to what extent infant brains tunes into and its activity becomes fine-tuned by social signals from their first social partner, which is usually their mother. So this is a way of basically looking at connectivity, not within the brain itself of the kid, but between brain of the kid and the mother and the caregiver. And through that, to come up with some social type of engagement. And on that, I stop and happy to answer any questions I have. I know it was a lot of material, but I'm sorry if I ran too fast. I can answer that now if you have a question about it.
Thank you very much for that talk. A couple of questions. One, I noticed the pattern, differences in appearance pattern in terms of children with ADHD and adults with ADHD. Do you think that's biomarkers, and then the second question, I may have asked you before, so I apologize. But is there work being done to differentiate founding variants kids with ADHD or kids with ADHD and ADHD?
As far as I know, so that the first question was, again,
the difference between the kids' patterns of coherence
right.
and the adults.
What I haven't shown here is that there is an age factor in ADHD. So even within the 5 to 16 years old, I see that there is some of areas changes with age. So I would say part of that is probably developmental, and then once we take that away, then we'll see what's left between them. But until I do that, probably developmental. But changes it, we all change. Yeah, I mean, right now I'm looking at brainwaves of people who are older than 65 and younger than 65, and just the normal, healthy everything. And you see quite a bit of difference. So I mean, yeah, change. Even at that age, it changes. Now, as far as the second one, that's one of the goals that we want to do at Schreiber. So this data has some measures of anxiety and so on. And we will include that in our next round. I have looked at adults as my VA research with PTSD, with depression, and with anxiety, and that there is a difference. A lot of times, the depression is the most powerful underlying factor, even to the PTSD part. So, and that's why the grant is really about trying to parse them with the comorbidity of markers that are PTSD and markers that are with the, depression and PTSD, and so on and so forth.
How about now? There we are. So thank you very much for the overview. I'm wondering about the meaning of the biomarkers. So this applies more to ADHD than the other things, but ADHD is, a committee got together and they decided that this syndrome is ADHD, right? There are many committees, right? But underneath it, there's problems with executive function, with attention, you gave a number of specific, well, in some of those, there were some specific executive and cognitive tasks. So one question is, what's the meaning of the biomarker, and would you come closer to finding out the meaning by looking at the same measures, but in people with and without a particular cognitive finding? So that's part A. And part B is coherence good or bad? I mean, is there any meaning behind coherence? Like, I could make up reasons why a brainwave would have trouble getting from the thalamic generator to the cortex, with some difference in the function of the brain underneath.
Okay.
So,
let me answer that one first. If I may. Coherence, is both good and bad. It's good when you need the information to go. But for example, in sleep, in REM, if there's too much coherence in PTSD, that others, you would not. So coherence is more than normal. So it cannot disengage from the troubles of the day. So you end up, having basically difficulty. Or in autistic children, if there's too much of the coherence going on, then the pruning that we talked about is not happening. So there's too much information at once, and so there needs to be a balance. In fact, what I'm finding from my PTSD work with the coherence is that it's not that between normals and PTSD that is one is always higher than the other one. It's really the balance among them. So some are higher, some are lower, but the kind of the ratio, you know what I mean? It's like an even keel of up and down. So
but for instance, if you're studying left versus right, which might be one way of doing it, I suppose, our brains are asymmetric. We know they're built differently on the two sides. For instance,
but in PTSD, that's not necessarily the case. There is still a difference. That's why you look at it. If there are hemispheric, coherences, and that is one of the markers of change. So it happens. As far as what to do with these biomarkers, with the PTSD, we're working on showing that two things: show the effect of medication or therapy, and see if the biomarker can pick up who responds. And actually, we want to see if we can pick that up sooner rather than later. So what we do a study, right before starting of the therapy, and within a week after that, and then 12 weeks after they do, whatever, and then 3 months following the end of therapy. And we are trying to find out if there is any way that these biomarkers can predict who would respond better to the therapy or not. So that eventual goal might be that, if we see that they are not responding, they might be change the therapy sooner rather than wait the whole 12 weeks. And the same thing could be done with ADHD and other ones too. I haven't done it, but these are the kind of things that, you're not using it for diagnosis or anything, but mostly like gauge the progression in a more, objective way that they're doing. But that's, to me, and then the question of separating them. Again, ADHD alone, ASD alone, and the ones that have both of them, it's my understanding that's a big problem in clinical. That, you don't know if a person, ASD person who is acting out, you want to give them Ritalin for his ADHD symptom or not, for example. So if you have a way of knowing that there is, ADHD is stronger than this person, so you might
I have a question from the Zoom manager. What role does the limbic system play in ADHD
et cetera, especially in PTSD?
Depends on, for PTSD, I know there are different types. In PTSD, there are different types. There are anxiety, the avoidance and all of that. And I do believe that limbic system is correlated to one of them. I just don't remember which one. Maybe that's... Dr. Benjamin, do you... Help me out.
Yeah. Some of us live in the limbic. So in terms of anxiety, obviously the amygdala is what's usually measured, in terms of how much response to anxiety producing situations are. So you can do imaging of the amygdala, and you can look at different sorts of biomarkers that involve the amygdala in PTSD. That's, as far as I know, that's more interesting than some of the other parts of the limbic system.
Sorry, based on that, I don't think that your EEG or fNIRS was able to access those deeper structures, though. So that maybe that's not getting looked at in this. You're really
Only
much
the
more.
surface one, yeah. So that's
So that's one piece that
Yeah.
perhaps is missing in that. But I think
no, but that's a good point. We can, if it's limbic, it's whatever is near the surface, so not the whole. Thank you very much. Thank you.